that brings on our next presentation by Dr. Wes Soliman on nasoenteric nasogastric tube placement is contraindicated in patients with documented varices.
All right. Hey guys, I'm Wes, one of the second years. Nice to meet you all. So it's not going to be as vulgar as that video was, but let's start. So quick introduction for all of us. Esophageal varices. I thought it was pretty interesting just to look at some of the percentages that we've seen all around. Around 30 to 60% of all cirrhotic patients can exhibit or have esophageal varices altogether, which is a clinically significant sequela of portal hypertension overall in more than half the patients altogether. And then what I found was interesting is acute event of variceal hemorrhage altogether could be around 6.4 to 16% despite standard therapy. And then the other thing that I thought was interesting, a 2-year bleeding risk was around close to 30%, which is pretty significant. And something I'm going to comment on, especially as a table on the right side or left of that, is the different indications that I've found through literature search of when and you should be putting NG2 placements altogether. We're going to highlight 2 of them here. The ones I'm going to be chatting with you guys about this time is going to be administration of medication, especially in malnutrition, and then hepatic encephalopathy are the 2 that I'm going to discuss. And in this here, just a quick overview of malnutrition, which I found in a lot of the articles that we kind of go through. They go into detail of the prevalence is one of them, how in compensated cirrhotic patients, malnutrition sarcopenia is about 20% in compensated patients, whereas in most of the ones that we admit and see on a daily basis is 60% have malnutrition and sarcopenia. The study that is highlighted here, especially about malnutrition, talks about the different etiologies, whether it's decreased oral intake, early satiety, anorexia, maldigestion, hypermetabolism as some of the causes. And then this is a study by American Association of Study of Liver Disease. It talks about the practice guidelines essentially for the management of malnutrition, frailty, and sarcopenia. Some recommendations do have the screening algorithm for it, full malnutrition in all admitted patients altogether. Their measurement strategies that they discussed in this study was a CT scan of the L3 skeletal muscle index, or SMI, and they look at the skeletal muscle area at L3 levels normalized to the height ratio, and based on that, they dictate if this patient meets that criteria or not. And what I also found was interesting is they had risk stratification for disease-specific sarcopenia, where alcohol-related liver disease is up to 80% prevalence with rapid muscle wasting. And the 2 highlighted on the left side is metabolic imbalance and hyperammonemia related myotoxicity, just kind of pathophase of what occurs and whether it's decreased protein synthesis, autophagy, and proteolysis. Now, the next indication that I'm highlighting is the management of hepatic encephalopathy as one of the reasons why they pushed or promoted NG2 placements as one of the reasons. And as we're all aware, it could kind of vary from mild cognitive impairment to coma altogether. These 2 studies, actually it's the same one, the practice guideline is again by the American Association of Study of Liver Disease, and it promotes what the indication or what the treatment is, which we're aware lactulose, for example, is as first-line therapy. Oral administration is preferred, but in some cases when they're in severe cognitive impairment or coma altogether, you're not able to administer that medication. And it kind of talks about rectal lactulose as well as adjunctive therapy and as well as the indication. What's highlighted on the bottom, I know it's a little bit hard for everyone to see, but it says, in the hospital, an nasoenteric tube can be used to administer oral strategies for patients who are unable to swallow or have an aspiration risk. Now, the next slide I'm going to highlight is to kind of give all of us a visual and numerical values. I'm going to go over the different types of NG tubes. As we're aware, they kind of vary from 5 French all the way to 18 French. The ones that are common here that we use, so small bore NG tubes are considered ranging from 5 to 12 French, and then large bore would be 12 to 18 French. The 2 that I'm highlighting here is the Salem sump and Dopoff. Salem sump is a double lumen, usually larger, more for suction and decompression, so it would vary between 12 to 18 French. The ones I've seen is around 16 French, essentially. And then the Dopoff that we also use as well, it's more of a smaller bore, and it's often used for feeding, essentially. And I won't highlight too much on 11, but it's more of a single lumen tube. Now, this takes us to the big point here. We're all familiar with UpToDate. When you go on UpToDate and kind of look up NG2 placement, you have contraindication highlighted there. And it says, again, it's hard for everyone to see. So what it says is, contraindication, nasogastric tubes should also be avoided in patients with esophageal varices because tube placement may trigger variceal bleeding, which can be life-threatening in patients with a bleeding diastasis. Minimal trauma to the pharynx, esophagus, or stomach from NG tubes can also lead to severe bleeding, and thus tubes are avoided whenever possible. So whenever you look up stuff on UpToDate, you always see that numerical value on the side to go to references and whatnot. What I found very interesting is nothing was referenced regarding that on UpToDate. There's about 52 references. There's not a single one that kind of comments on that or has anything in relation to any studies. And just keep that in mind as we go through this. Now, it was to kind of highlight it a little bit more, but it's not zoomed in, so we'll carry on. Before we get into it, I'm going to reference this slide and we'll go back to it again, but it just highlights the current society guidelines and recommendations. I'll start with the European Society for Clinical Nutrition and Metabolism, which that guideline kind of comments, and what you can see is kind of all across is this was essentially for the management of malnutrition and liver cirrhosis, with the recommendation saying you can use enteral tube feeds if inadequate oral intake cannot be administered altogether and cannot be maintained even in the presence of esophageal varices. If we highlight, maybe this was in 2006 essentially. If we go fast forward to 2020, 2019 and 2020, similar recommendations as well, stating there's lack of evidence that esophageal varices pose any unacceptable risk essentially to use fine bore nasoenteric tubes. And then I'll highlight the American Association of Study of Liver Disease, which I think has been highlighted in a lot of the studies or a lot of the research I did. It says the use of NG tubes for oral medication administration can be used even variceal bleeding was not directly discussed. Now, the one that's in 2021, comparison to the one in 2014, for example. So the one in 2014 didn't specifically state about the esophageal varices, but the one in 2021 and 2024, there's statements, if you guys aren't able to read it, but is the presence of esophageal varices was not an absolute contraindication for the placement of nasoenteric tubes, further highlighting the possible risk, but importance of close monitoring. And then recently, 2024, which states the presence of variceal bands, actually in this case, do not contraindicate placement of a feeding tube. And lastly, it's the American College of Gastroenterology, which, sorry, it was supposed to be linked on here, that consider any nasoenteric tube insertion safe, even in the presence of esophageal varices. And then let's get into the clinical studies briefly. Highlighting a couple studies that kind of mainly stratify. So this is an older study actually by Dr. Michael Ritter, essentially. It was done in 1988. And it was a cohort study that looked at, assessed the risk of GI bleeding patients with cirrhosis who underwent liver transplantation at the time. And interestingly, it was published in the International Anesthesia Research Society. It was a cohort study of total 75 patients. 61 of them had esophageal varices, with the primary endpoint or outcome was incidence of GI bleed, which was defined as hematemesis or bloody NG aspirate or melena throughout the intraoperative period. And the results of the conclusion of that, all the patients had rapid sequence induction, were intubated, followed by an 18 French standard Salem sump NG tube placement that was blindly placed. None of these patients had documented GI bleeds. Some of the limitation of the study, there was no control group or comparison group. And the conclusion was that the observed proportion of causes with variceal hemorrhage is around, essentially for them was 0%, with a 95% confidence interval for that population of about between 0 to 4.8%. And that's, in my opinion, is probably one of the better studies that I found, but 0 patients out of 61 with varices essentially had any, and it was all blindly placed. Now, the next one is actually a larger but most recent study. I think it was in 2019. Yeah, 2019. And it assessed the risk of variceal bleeding after nasoenteric tube placement in patients with known varices. It was a retrospective cohort study of around 75 patients with primary endpoint of, similar to prior, GI bleed that was defined as hematemesis, bloody NG aspirate, or melena within 48 hours of tube placement. And the secondary outcome or endpoint was about a 2-point hemoglobin drop within 48 hours without evidence of obvious bleed. The results of that study was 11 out of the 75 patients had a GI bleed within 48 hours of nasoenteric tube placement. And they made the association with most of these patients had a higher MELD score. So the association was made that higher MELD score was associated with higher risk of GI bleed after nasoenteric tube placement. And for the secondary outcome was about 9 patients out of the 75, so around 12% or so. Some of the limitations that I found were interesting is, again, non-controlled study. It also kind of raises the concern of, they didn't specify the type of or cause of GI bleed. It was just mainly, there's some aspirate of blood. They didn't quantify what it was. And what I also found interesting is none of them were anything documented regarding intervention, whether they had an endoscopy, had any sort of banding or sclerotherapy done. Again, also the sample size is something that I've noticed was one of the limitations in the study. But I think there was 2 patients that they said suffered about 2-point hemoglobin drop that were kind of significant in those patients. But other than that, let's see. Yeah. So these 2 studies that I highlighted initially, by the way, this just mainly looks at esophageal varices. They had no intervention. It was just stratified in that sense. Now the next one, and it's a question that I found was, I'm sure all of us ask and face on a daily basis, what about patients that have just been banded? Is it a contraindication to put an NG tube in? And if so, how long would you have to wait? I found this study. It's a small study from 1997. It took place between 94 to 95, essentially, and it was a randomized control study. And it talks about the risk. So it was to describe the risk of variceal bleeding due to NG tube insertion following recent esophageal banding or sclerotherapy. So very small study, only 22 patients had either sclerotherapy or banding for variceal bleeding. They were each assigned to receive either an NG tube or to remain NPO for 3 days. They found that 4 out of the 12 patients in that arm had rebleeding episodes on day 3, 4, and 5, compared to 1 out of 10 in the comparison group, essentially, or the NPO group. But what I found interesting is this study was highlighted in many cases, but it's criticized that in the fact that the groups were not balanced. For those of us that are not familiar, sclerotherapy is not usually done. We usually do more banding in this case, and sclerotherapy has been associated with higher risk of bleeding and rebleeding risk altogether. So 11 out of the 12 patients in that group that had the NG tube, 11 out of 12 had sclerotherapy, compared to the 7 out of the essentially other 10 patients that had in the comparison group had sclerotherapy. Further highlighting that the difference can be explained by the intervention, that as sclerotherapy is associated with higher risk of bleeding compared to banding, and we don't see it as often, I guess. This is an article that I kind of put into perspective because I thought it highlights this pretty well. It talks about that, and it kind of comments about one of the guidelines that we kind of highlighted on initially from the European Society. And it talks about the criticism that we just highlighted in saying that there's limitations and their recommendations, and what I kind of acknowledge in that area is that there's concern for the immediate days following a bleed, but they recommend 24-hour wait. But there was nothing essentially commented on in terms of where they came up with those 24 hours. They said, hey, based on the study, we're just gonna be safe and say 24 hours is recommended in this case. Now, this last study is probably the most recent. I think this was done in 2023, and it was a randomized control trial of 191 patients initially started. 111 were excluded, only 80 of them remained, and it was an open label designed, again, small sample size, only around 80 patients, 2 groups. They did, one group was 1 hour post-banding. They did esophageal or NG tube placement, and the other group went with standard therapy, which is standard care, which is 48 hours of sips of water and lemon water orally. The primary outcome was 5-day rebleeding in both arms, with the secondary outcome as 5-day infection rate, hepatic encephalopathy during hospitalization, and 6-week mortality. And it kind of commented based on the 2 groups. The outcome essentially was a 5-day bleeding risk after only 1 hour, with, I think there was, respectively, in comparison, there was very minimal. I think it was about 2% in each where they found, and It was rebleeding rates in esophageal enteral feeding was 2.5% and 5% in the NPO patients. And there was no difference in the secondary outcome altogether. And they essentially commented as early initiation of NG2-based feeding after endoscopy in variceal bleed appears safe and well tolerated without the additional risk of rebleeding or encephalopathy. And again, this is another study that I found. I was trying to figure out, every person I've talked to about how long do you wait, they comment on the 24 to 48 hour range, but there's nothing really, there was no meta-analysis, there was no arm-based studies that show I've waited 24 hours, there's 48 hours. This was the only study that I found actually that talked about the 48 hours, and it's a study that highlighted the different types of GI bleeds, indicated different types of waiting. The only 48 hours that were stated in that was regarding a gastric ulcer bleed, essentially. But their comment on there is, it was a review study from 2011, essentially, and it highlighted that the American College of Gastroenterology guidelines, depending if it's high versus low risk stigmata and extent of banding, the advisable waiting period is between 24 to 48 hours. And that was mainly decided as an intention to minimize risk of complication related to banding procedure in itself, including rebleeding or perforation. It's a universally accepted waiting period for the initiation of feeding, but most of the data and studies found highlight that magic number that I, again, had a very hard time finding from where most of these studies. And this is a quick summary of all the studies that I found. If you take out most of these, especially that they don't comment or delineate that all these patients have esophageal varices, most of them, at least the top 3 that I X'd out altogether, didn't have esophageal varices in most of these patients, and very low number. And then the other 2 that I found also didn't comment on the actual data or history of esophageal varices. So if you take most of these studies out, you have a very small sample size altogether, maybe around 200 patients in the last 30 years, 35 years based on the studies and these recommendations, with very negligible bleeding rates altogether. Back to the society guideline again, whether it's the European Society of Clinical Nutrition and Metabolism or the American Association of Study of Liver Disease or the American College of Gastroenterology, they all in agreement of the lack of evidence thereof that contraindicate the fact that you can put an NG tube altogether. And I know we kind of went over that in each and what they each one recommend, and I don't want to take too much time to limiting the point, but my last point that I found was interesting to kind of segue into this is, if there was such concern about an NG tube, a small 12 French, what about a TEE that's blindly inputted altogether? There was comments that I found in some of the review articles that talks about that it's contraindicated to do TEE in patients with esophageal varices, and that you would need a pre-procedure endoscopy and intervention to intervene on these patients prior to. And this is, again, a practice guideline from a well-known hepatologist at Rush that, again, highlighted that same question that I had. And was only found a great study actually that highlighted this. It's highlighted in the Journal of American Society of Echocardiography, is that probe placement and esophageal instrumentation are semi-invasive that carry potential risk. And it's a relative contraindication based on that guideline. Now, this study, essentially, it was a multi-center retrospective study of cirrhotic patients with and without esophageal varices, about 347 patients that were enrolled. 191 of them were included, 79 with documented varices. So the population we're looking at is about 79 patients. Primary outcome was overt manifestation of GI bleeding, again, the 48 hours of gross hematemesis, melena, or hematochezia, and or evidence of active or recent hemorrhage on upper endoscopy. The secondary outcome, similar to before, is also a 2-point hemoglobin drop within 48 hours post-DE. If we see here, again, it's probably very hard for everyone to see as well, the primary outcome had 0 in both. There was 0 patients, all had a TEE done, and there was nothing. There was, in the primary outcome, no bleeding within 48 hours. And what I found also, there was very low risk of overt GI bleeding following TEE in patients with cirrhosis and esophageal varices. And then the secondary outcome, if you compare, which is the 2-point hemoglobin drop within 48 hours, close to 30% without really much of a difference between, again, highlighting the endoscopy before TEE versus after. You have large esophageal varices altogether. I think there was 9% with pre and then 20% post, with very comparable pre and post for secondary outcomes, about 21% and 23%. Now, I'll jump to my conclusion based on all these studies. What I think we should probably, or what I think I got from all the research on esophageal varices and NG2 placement, yes, malnutrition and hepatic encephalopathy are both very important indications for NG2 placement, as patient outcome depend on it. And then based on, honestly, the evidence or lack thereof, and whatever current available studies that we have, there does not appear to be a contraindication for nasoenteric or NG2 placements in patients with esophageal varices. And then lastly, again, based on these variable and very little data, there's general recommendations based on all the consensus, based on all the guidelines from the ESPN, AASLD, and American College of Gastroenterology that the typical waiting period is 24 to 48, and they just err on the side of caution of, say, 48. But there's very little data regarding that. And then lastly, TE does not cause variceal bleeding, as we've seen in that most recent study, and then routine pre-procedure TE and or endoscopy does not mitigate the risk of bleeding, as we've seen with pre and post. And thank you all. And these are my references.
Any comments or questions? This comes up a lot, right? In the ICU, and I'm probably on the floors also. So I think it kind of highlights, what's that? It kind of highlights, what Mythbusters is all about. There's very little data here. I mean, even though all these societies now are saying, put the tubes in, you still could find very little data. We're talking about a couple of hundred patients, which is remarkable when you think about how common this problem is, and that there's just not even more studies being done. It's just, I thought that was amazing. So, yeah.
The 24 to 48 hours, is that based on the proceduralist who did the banding saying that?
This was, that's why I thought this was a review article essentially that kind of recommended that based on the guidelines. They didn't say it was the procedurist depending on that. When I chatted with GI specialists regarding that, they quoted the same exact thing of like 24, 48 hours, but out here on the side of caution, 48 hours. This was similar, yes. It's most of them are the GI specialists that are doing the banding that just say, just err on the side of caution and wait 48 hours. But when you look at any of these studies, there was nothing referenced or any studies that kind of show that they looked at patients waiting 24 hours versus 48 versus 72 hours. None of them. And then we have this study that showed 1 hour post-banding, putting tubes in, and very minimal bleeding altogether. So it's society guidelines and recommendations based on that.
I think you'll read this term a lot in these guidelines and other reviews. Expert recommendations, which means there's no data, right? Because if there were data, they would be citing the data. It's just people who, they pull that number out of wherever. They have no data to support it. It's just what they do. And that's why you see some say 24 hours, some say 48 hours, some say whatever. I don't know. Back there, a question, or he's just scratching his back.
Exactly.
Anybody else? Questions? All right, well, it's time to vote, I think. So is it a myth? Nasoenteric nasogastric tube placement is contraindicated in patients with documented esophageal varices. How many think this is true, that it's contraindicated? As up to date says that it's contraindicated, essentially contraindicated. How many think it's plausible? You? How many think this is busted? That looks like the majority.
I'll take it.
All right, we're busted.